I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 7 of our 8-part series on menopausal hormone therapy. And today we are tackling the episode that for more than 2 decades has probably generated more fear, confusion, and conflicting advice than any other aspect of menopause care: the risks of MHT. We're going to talk about breast cancer, blood clots, stroke, cardiovascular disease, when MHT really is contraindicated, and the much more interesting clinical territory where it isn't necessarily contraindicated, but the decision requires a bit more thought. We also need to talk about the study that changed menopause prescribing around the world, the Women's Health Initiative, or WHI. Because you cannot really understand contemporary attitudes towards MHT without understanding what happened in 2002. And finally, for people who cannot or do not want to use MHT, we'll talk about some of the alternatives, including the relatively new non-hormonal medicine fezolinetant, sold in Australia as Veoza. As always, I'll end with some reflective questions to guide your CPD recording. MHT is not either safe or dangerous. One of the problems with conversations about menopausal hormone therapy is that we keep trying to collapse a complicated clinical decision into a binary question. Is MHT safe? And that's not really the right question. A much better question is, for this particular person at this particular age, with this particular medical history, using this particular hormone by this particular route for this particular indication, what are the likely benefits and risks? Because MHT is not one drug. Oral conjugated equine estrogen plus medroxyprogesterone acetate is not biologically identical to transdermal estradiol plus micronized progesterone. Estrogen-only therapy is not the same as combined estrogen-progesterone therapy. Starting treatment at 51 is not necessarily equivalent to starting it for the first time at 72. And treating troublesome hot flushes in an otherwise healthy, recently menopausal woman is a very different clinical proposition from initiating systemic hormones specifically in an attempt to prevent cardiovascular disease. Current menopause guidance broadly supports the idea that for most healthy, symptomatic women younger than 60 or within approximately 10 years of menopause, the benefit-risk profile of MHT is favourable when there are no contraindications. So how did we become so frightened of it? We need to go back to 2002, the Women's Health Initiative. The Women's Health Initiative was enormous and important research. It should not simply be dismissed as a bad study. The mistake was largely in how its findings were extrapolated. The WHI hormone trials enrolled more than 27,000 postmenopausal women overall. In the combined hormone arm, women with a uterus received conjugated equine estrogens plus the synthetic progestin medroxyprogesterone acetate, and the average age of enrollment was around 63. So this is not predominantly a trial of 50-year-old women starting MHT because they have just developed hot flushes. Many participants were considerably older and well beyond the menopausal transition. The combined treatment arm was stopped in early 2002 after investigators found increased risks, including venous thromboembolism, stroke, coronary events, and invasive breast cancer, alongside reductions in fractures and colorectal cancer. And the headlines were extraordinary. HRT causes breast cancer. HRT causes heart attacks. Women stopped their hormones. Prescribing collapsed. Clinicians became frightened to recommend MHT, and a generation of women were left to manage significant menopausal symptoms without effective treatment. But as the data were subsequently examined in more detail, a more nuanced picture emerged. Firstly, the risks varied substantially according to age and time since menopause. Secondly, estrogen alone and combined estrogen plus progestogen did not produce identical outcomes. And thirdly, the preparations used in WHI were not identical to many of the MHT regimens we use today. Long-term WHI follow-up has been particularly interesting. Among women who had undergone hysterectomy and were randomized to conjugated equine estrogen alone, breast cancer incidence was actually lower than placebo during long-term follow-up. In contrast, the combination of conjugated equine estrogen plus medroxyprogesterone acetate was associated with an increased incidence of invasive breast cancer. That does not mean estrogen should now be prescribed to prevent breast cancer. It means the sentence MHT causes breast cancer is far too simplistic. The type of hormone therapy matters. Breast cancer. Let's deal with the issue that worries patients the most, breast cancer. For combined systemic MHT, estrogen plus a progestogen, breast cancer risk appears to increase with duration of use. But the absolute increase for an individual woman is generally small. And importantly, baseline breast cancer risk already varies enormously between women. Age, family history, alcohol intake, body weight after menopause, breast density, reproductive history, and genetics all contribute. MHT is one component of that risk profile, not the entire risk profile. Australasian Menopause Society information describes the increased breast cancer risk attributable to combined MHT as small and notes that it decreases after treatment is stopped. Estrogen-only therapy has not demonstrated the same increase in breast cancer risk. There is also continuing interest in whether the type of progestogen matters. Observational data suggests micronized progesterone and dydrogesterone may have a more favorable breast cancer profile than some older synthetic progestins, although we do not have WHI-sized randomized trials proving that distinction. So again, progesterone and progestogen cannot always be treated as interchangeable exposures when discussing risk. Remember our girl band. Beyoncé, estrogen, is not necessarily creating the same risk profile when performing solo as she is when another member of the band joins. It is the whole regimen that we are evaluating. What about women with previous breast cancer? This is different. Systemic MHT is generally avoided in women with a previous hormone-sensitive breast cancer because of concerns about recurrence. That does not mean every menopausal symptom in a breast cancer survivor must simply be endured. Non-hormonal options can be used for vasomotor symptoms. And as we discussed in the previous episode, genitourinary syndrome of menopause is a separate conversation. For selected women with persistent GSM after non-hormonal options have failed, low-dose vaginal estrogen may sometimes be considered through shared decision-making, including involvement of the treating oncology team where appropriate. Current menopausal guidance recognizes that this is a different risk proposition from systemic MHT. So this is why simply saying, she had breast cancer, therefore she can never use any form of estrogen anywhere, is too crude. Systemic exposure and low-dose local therapy are not the same clinical question. Venous thromboembolism. Oral estrogen increases the risk of venous thromboembolism, meaning deep vein thrombosis and pulmonary embolism. The mechanism makes sense pharmacologically. When estrogen is swallowed, it undergoes first-pass metabolism through the liver and affects hepatic production of multiple coagulation proteins. Transdermal estrogen, patches, gels, or sprays, avoids that first-pass hepatic exposure. Observational evidence suggests transdermal estradiol has substantially less effect on thrombotic risk than oral estrogen, and menopause organizations recommend considering transdermal therapy where VTE risk is a concern. So if someone has obesity, a strong family history of thrombosis, increased age, reduced mobility, or other thrombotic risk factors, route becomes clinically meaningful. So it isn't just, would you prefer tablet or patch? It may be, which route gives us the more favorable risk profile? A previous unexplained VTE or known thrombophilia requires considerably greater caution and usually specialist input, but again, risk factors exist on a spectrum. Stroke and cardiovascular disease. The cardiovascular story is another legacy of the WHI. MHT should not be prescribed specifically for the primary prevention of cardiovascular disease. This is important, but that statement is very different from saying MHT causes heart disease. Age and timing matter. Starting MHT in a symptomatic woman close to menopause appears to have a considerably more favourable cardiovascular profile than initiating systemic hormone therapy for the first time many years after menopause. And that observation contributed to what is often called the timing hypothesis. If a woman already has significant atherosclerotic disease, established coronary disease, previous stroke, or multiple uncontrolled cardiovascular risk factors, systemic MHT becomes a more complex decision. But ordinary cardiovascular risk factors should not necessarily trigger an automatic no. They should trigger cardiovascular risk assessment: blood pressure, lipids, smoking status, diabetes, weight, family history, and then, importantly, appropriate treatment of those risk factors. Because declining to treat women's severe hot flushes while ignoring her untreated hypertension and smoking would be a peculiar interpretation of risk management. Migraine. Migraine's another area where patients are sometimes unnecessarily told they simply cannot have hormones. Migraine itself is not an absolute contraindication to menopausal hormone therapy. Migraine with aura is particularly relevant to thrombotic risk when we are discussing the combined oral contraceptive pill, which contains a much higher potency hormonal exposure than standard menopausal hormone therapy. That evidence should not automatically be transferred across to MHT. For menopausal women with migraine, stable transdermal estradiol is preferred because it creates less fluctuation in hormone levels than oral therapy. In fact, fluctuating estrogen itself can be a migraine trigger. So sometimes the clinical issue is not avoiding estrogen altogether, it's avoiding dramatic hormonal peaks and troughs. What about hypertension? Well, controlled hypertension is not automatically a contraindication to MHT. Severely uncontrolled hypertension is different. Blood pressure should be assessed and treated appropriately before systemic therapy is initiated. And again, transdermal estradiol may be preferable in women with cardiovascular risk factors. This is one of the recurring themes of this episode. Risk rarely sits in a yes or no box. Often it changes which preparation we choose. Liver disease. Because oral hormones are metabolized through the liver, significant active liver disease is an important contraindication or reason for specialist assessment. This is particularly relevant if there is impaired hepatic function, cholestatic disease, or unexplained abnormal liver tests. And interestingly, liver monitoring has also become a major issue for one of our newer non-hormonal treatments, which brings us to Veoza. Fezolinetant is sold in Australia as Veoza, is genuinely interesting because it represents an entirely different way of treating menopausal hot flushes. It isn't estrogen, it isn't progesterone, and it isn't an antidepressant being repurposed for vasomotor symptoms. Fezolinetant is a selective neurokinin 3 receptor antagonist, or NK3 receptor antagonist. It targets the thermoregulatory circuitry in the hypothalamus involved in hot flushes. During menopause, declining estrogen alters signaling through neurons involved in temperature regulation, particularly the Kindi neuronal system. That narrows the thermoneutral zone. Essentially, the body becomes much more likely to interpret a very small change in core temperature as, "We are boiling, everyone panic. Cue vasodilation, sweating, hot flush, night sweat." Fezolinetant blocks neurokinin B signaling at NK3 receptors and helps stabilize that thermoregulatory system. In Australia, Veoza 45 mg once daily is TGA approved for moderate to severe vasomotor symptoms associated with menopause. And this gives us another option for women who cannot use MHT or simply do not want it. But there is a major safety update that clinicians need to know. Post-marketing cases of serious but reversible hepatotoxicity have occurred with fezolinetant, including cases within approximately 40 days of starting treatment. The Australian product information was therefore strengthened. Baseline liver tests, ALT, AST, alkaline phosphatase, and bilirubin should be performed before treatment. Veoza should not be commenced if ALT or AST is at least twice the upper limit of normal, or if total bilirubin is at least twice the upper limit of normal. Once treatment begins, hepatic laboratory testing is recommended monthly for the first 3 months, then at 6 months and 9 months, with further monitoring according to clinical judgment. Patients should also be counselled to stop treatment and seek medical assessment if symptoms suggest possible liver injury, such as new fatigue or reduced appetite, nausea, vomiting, itching, jaundice, pale stools, dark urine, or abdominal pain. This is an important update because when fezolinetant first became available, clinicians may have regarded it as a relatively straightforward non-hormonal alternative. It remains a useful medicine, but non-hormonal does not mean risk-free. And that's another useful lesson for this entire series. Every effective medicine has pharmacology, and pharmacology has consequences. Other non-hormonal options. Fezolinetant isn't the only alternative when MHT is inappropriate or unwanted. Certain SSRIs and SNRIs can reduce vasomotor symptoms. Gabapentin can be particularly useful when night sweats and disrupted sleep predominate. Oxybutynin has evidence for vasomotor symptoms, although anticholinergic adverse effects can limit its use. The Australasian Menopause Society no longer recommends clonidine for vasomotor symptoms because of limited efficacy and adverse effects. The important point is that the treatment should match the symptom. If the major problem is hot flushes, we treat hot flushes. If it's GSM, we treat GSM. If it's insomnia without vasomotor symptoms, throwing estrogen at every case of insomnia in a 52-year-old is not necessarily good menopause medicine. Which brings us back to individualization. Another common misconception is, you turn 60, we have to stop MHT. There is no magical birthday at which a patch suddenly becomes toxic. The issue is that initiating systemic MHT for the first time after 60 or more than 10 years after menopause generally carries a less favourable risk-benefit profile than starting around the menopausal transition. Continuing established therapy is a separate discussion. If a woman remains asymptomatic and understands the potential risks and benefits, treatment may sometimes continue beyond 60 or 65 with regular assessment. There is no universal rule that everybody must stop at a particular age. Dose, route, indication, and involving medical history all need review. Unscheduled bleeding. One complex situation we should never brush aside is unexpected bleeding. Bleeding can be common when commencing or changing MHT, particularly during the first several months, and sequential MHT intentionally produces withdrawal bleeding, but persistent, heavy or new bleeding after a period of amenorrhea needs assessment. Do not simply keep escalating the progesterone indefinitely and hope it disappears. Think about adherence. Is the patient actually taking the progesterone? Is the dose adequate for the amount of estrogen being used? Are there polyps, fibroids, endometrial hyperplasia, or less commonly, but importantly, malignancy? Abdominal bleeding should be appropriately investigated before simply attributing it to the hormones. The patient with multiple risk factors. And this is where menopause medicine becomes actual medicine rather than a prescribing algorithm. Imagine a 57-year-old woman. She has severe hot flushes, her sleep is dreadful, she has migraine, her BMI is 33, her blood pressure is mildly elevated, and her mother had breast cancer at 74. She still has a uterus. Does she have a contraindication to MHT? Not necessarily, but she certainly deserves more than, here's a combined oral tablet, see you next year. We might optimize her blood pressure, assess her cardiovascular and breast cancer risk, consider transdermal estradiol rather than oral estrogen, select an appropriate form of endometrial protection, discuss what we know and importantly what we don't know about breast cancer risk, and then let her participate in the discussion. This is shared decision making, not MHT is perfectly safe and not MHT is dangerous. Instead, here are the likely benefits, here are the potential risks, here are the ways we can modify some of those risks. What matters most to you? Risk needs perspective. Medicine becomes very difficult when we communicate risk without context. A relative risk can sound terrifying, a 30% increase, a 50% increase. But if the baseline risk is extremely small, the absolute risk may be small. Conversely, a modest relative increase may matter enormously in someone whose baseline risk is already high. So whenever possible, talk about absolute risk and compare like with like. We routinely accept small medication risks to treat hypertension epilepsy, autoimmune disease, depression, and pain. Menopausal symptoms deserve the same rational clinical assessment. Women should neither be frightened away from effective treatment nor persuaded that hormones are some sort of longevity elixir without meaningful downside. Both extremes are unhelpful. So who should not routinely receive systemic MHT? Rather than pretending there is one perfectly universal list, think in broad categories. Systemic MHT would generally be avoided or require specialist consideration in someone with a current or previous hormone-sensitive breast cancer, unexplained vaginal bleeding that has not been investigated, active significant liver disease, previous arterial thrombotic disease such as myocardial infarction or stroke, or significant previous venous thromboembolism or thrombophilia where the risk has not been appropriately assessed. And then there are situations that are not necessarily contraindications but change the conversation. Migraine, hypertension, obesity, diabetes, strong family history of breast cancer, older age, long interval since menopause, cardiovascular risk factors, and complex gynecological history. Those are not reasons to stop thinking, these are reasons to start thinking. So where have we landed? After 7 episodes, our girl band is looking slightly less simple than when we first introduced them. Beyonce, estrogen, is phenomenally effective, but the root matters. Adele, progesterone, protects the endometrium, but the type of progestogen may matter for tolerability and potentially long-term risks. Pink, testosterone, has a much narrower evidence-based role than social media sometimes suggests. And sometimes the right answer is that the girl band doesn't perform at all. Maybe the person doesn't need hormones. Maybe they don't want hormones. Maybe there is a genuine contraindication. And occasionally we bring in a completely different act, like fezolinetant, to target the symptom through another biological pathway. That is good prescribing. Not being ideologically pro-MHT, not being anti-MHT. Being pro-patient and pro-evidence. Here are some reflective questions. When discussing MHT risks, am I considering the woman's age, time since menopause, baseline risk, and the specific hormone regimen, or am I treating all MHT as one intervention? Can I explain why the findings of the Women's Health Initiative should not automatically be extrapolated to every woman starting contemporary MHT around menopause? When thrombotic or cardiovascular risks are a concern, have I considered whether transdermal rather than oral estrogen may offer a more appropriate risk profile? Do I know which histories represent genuine contraindications to systemic MHT and which require individualized assessment rather than an automatic refusal? If recommending fezolinetant, do I know the Australian liver function monitoring requirements and the symptoms of hepatotoxicity patients should be counselled about? That brings us almost to the end of our MHT series. In the final episode, we're going to move outside the prescription pad. We'll look at phytoestrogens, herbal products, and the enormous supplement market aimed at perimenopausal and menopausal women. What has evidence? What probably doesn't? And where natural can become a very effective marketing strategy. That menopausal care is also much bigger than treating hot flushes. So we'll finish by talking about things that genuinely matter for long-term health through midlife and beyond. Strength training, preserving muscle and bone, getting enough protein, nutrition, cardiovascular health, sleep, and the lifestyle foundations that no supplement can replace. Because hormones can be incredibly useful, but they were never supposed to do the whole job.